Welcome to episode 31 of the Pro PA podcast. I'm your host, Prof. G. Today, we're wrapping up our obstructive pulmonary diseases series with a high-yield episode on cystic fibrosis, or CF for short. Cystic fibrosis is a complex, multi-system genetic disease that primarily affects the lungs and digestive system. We'll break down the pathophysiology, clinical presentation, diagnosis, and management strategies so you're fully prepared for both the PANCE and real-world practice. Let's dive in. First, let's look at the kinder patho. What is cystic fibrosis? Cystic fibrosis is an autosomal recessive genetic disorder caused by mutations in the CFTR gene, which stands for cystic fibrosis transmembrane conductance regulator. That's a mouthful. The CFTR protein is responsible for regulating the movement of chloride ions and water across cell membranes. So think of it as a disruption of chloride passing. And the mutations in the CFTR gene result in defective or absent CFTR proteins, which lead to thick, sticky mucus production in the lungs, pancreas, and other organs. And it also reduces the water content in secretions, making them harder to clear. In the lungs, this mucus blocks airways, promotes infection, and causes chronic inflammation. In the pancreas, mucus blocks enzyme secretion, leading to malabsorption and malnutrition. So, what are the risk factors? Well, it really comes down to genetics. CF is an autosomal recessive disorder, so both parents have to carry a defective CFTR gene, and it's most commonly in individuals of Northern European descent. So, we're looking for a family history, like a sibling with CF, which will significantly increase the likelihood of inheritance. All right, clinical presentation. So, pulmonary manifestations. They're going to have chronic productive cough with really thick sputum, and they're going to have recurrent pulmonary infections, especially think Pseudomonas aeruginosa, okay, or Staph aureus, but mostly Pseudomonas. We also are going to see some wheezing and dyspnea, and we might see some digital clubbing from the chronic hypoxemia on their fingers. As far as gastrointestinal manifestations, we will often notice pancreatic insufficiency. So they will get malabsorption of fats and proteins, which will then lead to steatorrhea, or this foul smelling, greasy stool, and failure to thrive because they're not absorbing those proper nutrients. They also often present with a meconium ileus as a newborn, and that's often the first sign of cystic fibrosis. Patients can also get recurrent pancreatitis. Other symptoms can include sinusitis due to the mucus plugging. They can get chronic sinus infections. They also often, the male patients have infertility due to congenital absence of the vas deferens. And they can have electrolyte abnormalities like salt loss, which can lead to dehydration or hypochloremic alkalosis. Diagnosis. Well, in every newborn screening here in the United States, most cases are detected through this routine newborn screening program using the immunoreactive trypsinogen, or IRT. Another way that we can diagnose is via the sweat chloride test, and this is considered the gold standard diagnostic test for CF. Chloride concentration of greater than or equal to 60 is considered diagnostic. We can also do genetic testing, so this can help identify mutations in that CFTR gene, particularly if the sweat chloride test is inconclusive. We also do pulmonary function tests, or PFTs, on these patients, and this will often demonstrate an obstructive pattern with a decreased FEV1 to FVC ratio. However, I do want to make a small point here. We are putting cystic fibrosis in the little obstructive disease box because that's how it's listed on the PANCE. There is some variability in how this is presented in textbooks, where they say that it's mostly obstructive process, but it can have some restrictive properties as well. Other tests that we can do include sputum cultures. They're frequently going to reveal that Pseudomonas or Staph aureus, and the fecal elastase. and that is going to be used to assess pancreatic insufficiency. All right, let's look at the management. So, pulmonary care, we're going to help patients with airway clearance therapy. So, chest physiotherapy and procedural drainage to loosen and clear that thick mucus. They have devices like what they call oscillatory vests, which basically shake the chest. They put on like a vest and they help break up that mucus. They also have positive expiratory pressure or PEP masks. They also use mucolytics that help break down the mucus. So there's one called Dornase alpha or pulmozyme, and this helps break down DNA and mucus to thin secretions. They also use hypertonic saline, which helps improve mucus clearance. They also use bronchodilators for symptom relief, like albuterol. They also have to consider infection management because these types of patients get frequent infections and require antibiotics. So we have to consider oral, IV, or inhaled antibiotics, especially for Pseudomonas. And chronic use of azithromycin may also help reduce exacerbations. For the pancreatic insufficiency, we're going to use pancreatic enzyme replacement therapy or PERT, and this is necessary to improve fat and protein absorption. We're also going to give them fat soluble vitamin supplementation for the A, D, E, and K vitamins. There are plenty of medications out there for cystic fibrosis, and I feel like it's a field that's constantly reinventing itself and coming up with new treatments. So I definitely don't think that for your PANCE you're going to go into a deep dive of these types of medications, but just for thoroughness, there are some CFTR modulators which have revolutionized cystic fibrosis therapy by targeting the underlying genetic defect. And there are several medications here, including Ivacaftor, which is for patients with gating mutations, and other medications which are kind of hard to prescribe, and I doubt they test you on that, but these are for different types of mutations of the CFTR gene. In addition to these advanced therapies, we're going to give nutritional support, high calorie, high fat diets. This will help address that malnutrition and increased energy needs. And then lung transplantation. So, this is considered for patients with advanced cases of respiratory failure or severe decline in FEV1. All right, complications. There is a long list of complications that can arise from cystic fibrosis. Let's look at the pulmonary complications first. So, these types of patients get those recurrent infections. They also have bronchiectasis and respiratory failure. GI complications are going to include intestinal obstruction, pancreatic insufficiency, and cirrhosis from biliary disease. Endocrine complications, you can get cystic fibrosis related diabetes or CFRD. Now, bookmed versus streetmed. Bookmed textbooks are going to emphasize aggressive airway clearance, early antibiotic treatment for infections, and CFTR modulators as game changers in care. It's going to emphasize multidisciplinary care with pulmonology, gastroenterology, and nutritional specialists. Street med. So, in real life, adherence to airway clearance therapies may be a major issue, particularly in adolescents and young adults. Also, CFTR modulators can be life changing, but they are expensive and they're not always accessible to all patients. Last but not least, chronic infections with Pseudomonas are extremely difficult to fully eradicate, requiring repeated course of antibiotics. And there are lots of different strains of these different bacteria that patients can harbor and colonize within their lungs, and it can be notoriously difficult to treat. So much so that certain cystic fibrosis patients actually have to stay away from other ones to limit the transmission of these specialized bacteria. So, some quick clinical pearls before we wrap up. Cystic fibrosis should always be suspected in young patients with recurrent pulmonary infections, failure to thrive, or digital clubbing. A sweat chloride test is the gold standard for diagnosis, but genetic testing is increasingly used. Airway clearance is the cornerstone of pulmonary care. Encourage adherence with your patients. CFTR modulators are revolutionizing CF treatment and improving life expectancy. And watch for CFRD, which is cystic fibrosis related diabetes in adolescents or adult patients with CF. All right, let's go on to our knowledge check. Question 1. We have a 3-year-old child who presents with recurrent respiratory infections, failure to thrive, and foul-smelling stools. Sweat chloride test reveals a chloride concentration of 75. What is the next best step? Is it A, start bronchodilators and antibiotics for pulmonary symptoms? B, refer for genetic testing to confirm the diagnosis? C, prescribe pancreatic enzyme replacement therapy? Or D, initiate CFTR modulator therapy? Well, the answer for this is actually prescribed pancreatic enzyme replacement therapy. And so, sweat chloride test confirms CF and pancreatic enzyme replacement therapy is necessary for malabsorption and failure to thrive. The other interventions will follow in the treatment plan. All right, let's go on. A 16-year-old female with CF presents with increased cough, dyspnea, and green sputum production. Sputum culture grows Pseudomonas. What is the most appropriate treatment? Is it A, oral azithromycin, B, inhaled tobramycin, C, high-dose oral corticosteroids, or D, intravenous ceftriaxone? I'll give you a few seconds. If you said B, inhaled tobramycin, you're actually right. So, inhaled antibiotics like tobramycin are the treatment of choice for chronic or exacerbated Pseudomonas infections in CF patients. All right, I want to thank you for joining me in this episode, and I hope it helped you better understand this complex condition from its genetic underpinnings to its multi-system manifestations and life-saving treatments. As always, stay tuned for future episodes of the Pro PA podcast, where we'll continue to break down high-yield topics for panceprep and clinical practice. And if you found this episode helpful, don't forget to follow the podcast and turn on notifications so you never miss an update. And as always, this is the Pro PA podcast, where future pros in medicine are made. I'll catch you in the next episode.